today. This is Dr. George Pantalos, who got his PhD. He is a Buckeye at the Ohio State University. And after spending 17 years at the University of Utah, he came to the University of Louisville in 2000. And he's professor of cardiovascular and thoracic surgery. You might know him from FDA class. He is adjunct professor, I guess, with bioengineering. So today he's going to talk a little bit about his work in low gravity situations, cardiovascular wise. So Dr. Pantalos, the floor is yours here. This is fresh, brand new. Don't put anybody's eye out.
Can the lights come down a little bit? There we go.
Good.
Yeah, it'll show up a lot better. Well, it's nice to meet with you. Some of you I know probably more than you wish you knew me. Some of you I'm just getting acquainted with, and some of you are somewhere in between. And I know I've run into some of you on the basketball court. But regardless of the situation, it's nice to be here and share with you some of the adventures that I've shared with lots of folks with and without gravity. Probably one of the most important things of this whole presentation is to point out this line right here, the constellation of talented students and collaborators, because that's what makes these kind of adventures happen. And I'd like to point out a couple. Sitting right here in the front row is Dr. Keith Sharp, who's in mechanical engineering. Keith and I have collaborated for, well, let's just say a very long time, because he and I were at Utah together, and then circumstances fortuitously transpired for Keith and I to continue to collaborate once we both arrived here at the University of Louisville. And Tommy and I have known each other since I came here. We played a lot of basketball together, but in recent years we've had a chance to start to collaborate as well. And I know that there are some students here on the student senior design teams that will be working with us this semester, so you'll have a chance to continue this tradition that started 20-some years ago. Two other comments I'd like to make. If you get nothing else from this presentation, I'd like to do two things. There is always a role for students to be involved in the research. And throughout the slides, you'll see lots and lots of students, undergrads, grad students, medical students, and hopefully, if you're interested, there will be a chance for you to participate and share this kind of adventure as well. And the other message is the United States, with its international partners, is still very active in human space exploration as well as non-human space exploration, and it's only going to get better. So you don't hear a lot, but we're actually going to be going back to the moon probably in about 5 years. And some of what we're doing right now is supporting that effort. So stay tuned. Now, most of the time I spend working on ways to treat patients with heart failure. Developed a lot of artificial hearts and ventricular assist devices and helped implement them clinically and test them in the lab. But there's a lot of folks around here who do a lot of that work, and you've probably heard them speak as well. So I'm going to share a completely different adventure with you today. I also do a lot of work in pediatric devices, both developing this simulator, the cardiovascular system, which is another project Tommy and I are working on together, as well as developing pediatric circulatory support devices. But I'm going to share with you some of my adventures with NASA. Of course, every presentation has to have its disclaimer, and this is mine. This is my third grade report card from Maysbrook Elementary School in the north end of Columbus, Ohio. If you open it up, the grades on the left side are the stuff nerds are made from, but that's not what's important. What's important is the right side, personal and social growth, which you can see I was practically devoid of any personal and social growth, except for one line I excelled. In fact, I did so well they made sure my parents knew during the third grading period, and that line is talks too much. So, and I'm going to spend the next 4 hours proving that even though I'm a better public speaker than I was in the third grade, I still talk too much. Don't hesitate to interrupt with questions. So, by way of brief introduction, I started out as a rocket nerd. I then became a cardiovascular surgery nerd, and eventually I found a way to put them together to become a cardiovascular rocket surgery nerd. That's part of how I got to where I am today. And the other thing is all of my teams wear red. I did all my academic training at Ohio State, as Tommy mentioned, and I spent 17 years at Utah, where I had a chance to get well acquainted with Keith, and then I landed here at the University of Louisville. So it's great. I haven't had to change my wardrobe. You have checks to see which logo is on my red shirt, but it's usually in a red shirt. And the other, oh, I guess I didn't put it. My other team that wears red is the Red Cross. I've been a volunteer at the Red Cross for years, mostly related to blood services. And nationally, we are currently under what's called an appeals, which means that we're critically low level of blood products. So if you happen to be a blood donor, platelet donor, plasma donor, I encourage you to do that. Now, this is the current vision that NASA has for its space exploration. Where we are now is on the left. This is the International Space Station. We're in low Earth orbit. For years, the shuttle worked in low Earth orbit, doing experiments, creating the International Space Station, getting it up and running. We now have commercial resupply vessels, and for the last several years, the Soyuz spacecraft that the Russian Space Agency operates has been taking crews to and from the International Space Station. In the next few years, we will be seeing commercial crewed vessels, Boeing, SpaceX, and other companies taking crews up to the space station. But what we also want to focus on is getting beyond low Earth orbit, out to the moon, and eventually to Mars. And to do that, we'll do that with the Orion spacecraft and related spacecraft. Orion is kind of like a scaled-up Apollo. And it's well into development. This is the artist's conception of what it's going to look like when it takes off. The crew rides in the spacecraft at the very top of this. Nominally, it will have a crew of 4. It can be fitted up to a crew of 6. And just a few weeks ago, there was a very important milestone. Just like the space shuttle, the Space Launch System has 2 solid rocket motors on either side of it that fire for the first 2+ minutes to really help it accelerate quickly and get in its way up to orbit. And these are being developed by ATK, what used to be Thiokol, out in northern Utah. And part of their contract requirements is every once in a while to do a static test firing. So they'll take one of these motors, clamp it down to the test stand, and then fire it and measure the thrust and temperature and pressure and all that kind of stuff. So this is seeing one when Keith and I were out in Utah. It was a great field trip to take some students out to see these tests. But there was one just like it, but with an extra segment that they'll use that was test fired 4 weeks ago, and it went really well. So that's one more important milestone toward eventually getting the Space Launch System to fly. The first test of the fully assembled Space Launch System with an Orion on top of it will come in 2018, and if that one goes well, the first mission with a crew will be in 2021, and that will probably carry a crew of 4, and that mission will go to the moon according to current flight plan. They won't land on the moon, they'll go around the moon, still debating whether they'll actually go in the lunar orbit and come back. But the point is they'll have a chance to test most of the aspects of what it will take to get a crew back on the surface of the moon. Now, my heart has always been in space. Unfortunately, a few years ago, the Hubble Space Telescope actually got a picture of the Earth. And I've always been interested in how the cardiovascular system responds to the weightlessness of spaceflight and then readaptation once the crews come back. And these are some of the different experiments that I and colleagues like Keith and students have had a chance to participate in. And what I'm going to do is share with you a few observations of how the heart works related to how gravity affects the heart so that you can then begin to get some insights into what happens when gravity isn't possible. And there's 2 main phases of the heart. There's diastole, that's the phase where the heart fills with blood, and then there's systole, the phase where the heart muscle contracts to pump that blood out to the blood vessels in the body. What I'm going to focus on right now is diastole, the filling phase of the heart cycle, and 5 different physical factors that influence diastole. First one is the pressure inside the atrium or the receiving reservoir as the blood comes back from the body. The second would be the inertia of the blood as it goes from the atrium into the ventricle. The third is the pressure outside of the heart, inside the chest, which creates then a transmural pressure across the ventricular wall. The fourth is a passive elastic recoil that is a consequence of the parallel elastic element in the muscle elements. And then the fifth would be a small but measurable and physiologically consequential hydrostatic pressure difference because of the size and how the heart is oriented. In an average person, this could be possibly 5 millimeters of mercury, which, if you remember Frank Starling law of the heart from physiology, a 5 millimeter difference in atrial and ventricular pressures can practically double the amount of filling of the ventricle, so it's quite substantial. Now, I'll mention very briefly the same systole and diastole for an artificial heart, only because some of the experiments that we've done have involved subjects with artificial hearts and subjects with natural hearts. There's some things that are common and some things that are different that actually allow you to get some insights. Whether the artificial heart is actuated by compressed air or a mechanical pusher plate or hydraulic fluid, there's always some kind of flexing diaphragm that separates the actuator from the actual blood inside the heart. Like a normal natural ventricle, it also has an inflow valve and an outflow valve. And with impulsible devices, like the natural heart, it goes back and forth between diastole when it fills and systole when it ejects blood. And in the case that there's an increase in blood during diastole, then you get an augmentation of the stroke volume, or the amount of blood that's pumped per beat. So that, if the heart rate stays the same, that's going to increase your cardiac output. So there's a few different things in here that could influence diastolic function that become part of this story. One of the things that we learned from artificial heart patients is that if we needed to increase the cardiac output during diastole, or the filling phase, if we actually applied a vacuum, a small vacuum, maybe 5 millimeters of mercury pressure vacuum up that pneumatic line, in essence what we do is we draw the diaphragm down a little further, and that draws more blood into the heart without actually adding more volume to the circulating fluid volume. So here you see a ventricular function curve, the cardiac output as a function of the atrial pressure. And by applying a slight vacuum, we can actually, at the same atrial pressure, increase the cardiac output by a liter a minute, which is quite substantial. Or we could shift it to the left and operate at a lower pressure, or get a combination of the two in between. This phenomena actually is going to be important as we look at a couple of situations, one of which is what happens to diastole when you stand up, and what happens to diastole when you go from a 1G environment to a 0G environment. Because it wasn't completely clear when the opportunities to study astronauts in space first came up. This is a very simple test called a tilt table test. You have a test subject, in this case it happens to be me, laying on a horizontal table, and then you slowly tilt them up so that they're upright. And I had a multi-sensor catheter that was inserted in my nose and advanced down toward my toes, but one of the pressure sensors was in my esophagus, so inside my chest, measuring the pressure inside the chest. And the other was down in my small intestine, so it was measuring intra-abdominal pressure. And as you can see, as I went from supine to upright, my intraesophageal pressure went down, my intra-abdominal pressure went up. And part of that is just shifting of bodily contents, but part of it is also the interconnected biomechanical response of the elastic chest wall, the diaphragm, which separates the chest from the abdomen, and then the abdominal contents, and the fact that this is both physically and fluidically coupled. Now, how this works with an artificial heart patient, because the heart is rigid, it doesn't experience the change in the reduction in the intrathoracic pressure, which would increase the transmural pressure that would draw more blood back into the heart, even though blood is also going to want to tend to pool in the lower legs. So this is a tracing of a continuous monitoring of cardiac output in one of my artificial heart patients. And what happened at point A is I asked him to go from laying in bed to stand up without making any adjustments to the heart controller at all. And you can see what happened was his cardiac output dropped by about 1 liter to 1.5 liters. But then at point B, I added an additional 5 millimeters of mercury vacuum during diastole in his drive line, in essence to restore that reduced intrathoracic pressure that someone with a natural heart would experience. And what that does is it then restores the cardiac output by drawing more blood into the heart at a lower pressure. So the concept of transmural pressure is going to be visited again as we go through this discussion. Now, a couple of other anecdotal observations. I was doing one study trying to look at the motion of valves in an artificial heart. So we had a high-speed camera set up. We had a transparent ventricle set up so that when we looked at it, we could watch the movement of the inflow valve and the outflow valves as we went through systole and diastole. But unexpectedly, what I also noticed was the movement of the diaphragm. And as you know, with any medical device, it has its dogma about why it's so good and all that kind of stuff. And the one thing, this is a Jarvik 7 artificial heart, was because it had a hemispherical diaphragm that the stresses would be randomly distributed. And this was a good thing because that would hopefully increase the lifetime of the diaphragm before it would finally fail mechanically. The only problem with that dogma is that if you looked at the diaphragm movement, it always started to fill at the same place. And it started to fill toward the dependent-most portion of the ventricle, or the lowest portion, because the hydrostatic pressure inside the ventricle is greatest there, and so it would start to flex there. And then I forgot about it for several years and had to recall this little observation as we got into the spaceflight experiment. Now, the first opportunity to actually track cardiac function came on a space shuttle flight in 1985, STS-59B. And that was the first flight where an echocardiograph that can give you real-time imaging of the heart during systole and diastole was possible. Ray Seddon, who's a physician, was one of the mission specialist astronauts. And as it turns out, our senator from Utah at the time, Jake Garn, was one of the payload specialists. And he also wound up being one of the test subjects for this experiment. And here you can see Ray has the echo probe on his chest, and she's collecting images of his heart. And the data that came out was the following. They collected data before flight, first day in flight, and then each day during the flight. This was a 7-day mission, and then a few times after the flight. And from the echo data, they could see that initially, with entry into weightlessness, the end diastolic volume, or the filling of the heart, was bigger. But then as the flight went on, the volume got back to normal, and then it actually got about 15% below what it was pre-flight supine. So why is the heart increasing in size initially, and then why is it decreasing? Now, as it turns out, even though the stroke volume, or the amount of blood per beat, was a little slower, as a compensatory mechanism, the regulation mechanism made the heart beat a little bit faster. So the overall cardiac output that delivered was about the same in flight as it was pre-flight. So the astronauts weren't in any metabolic deficit, but still there's this curious observation of why is, after a while, the heart smaller than it was before flight, but why was it bigger initially? And like most physiologic processes, there's things that tend to increase the response and things that tend to decrease the response. And they don't always happen in the same time frame. And so ultimately, what we think what was happening is something was happening as soon as you entered weightlessness to make the heart fill more. But at the same time, there were things that weren't quite as apparent that were making the heart fill less. And initially, the balance point was for a bigger heart, and later, when things evened out, it was for actually less filling. There was another observation a few years later, which was the first time an astronaut had a chance to fly with a pressure catheter near his heart. It was in the Suborbital cava right outside the right atrium. And again, the dogma was when you entered weightlessness, because your cardiovascular fluid is going to shift toward your head and toward your heart, that pressure, the filling pressure, the atrial pressure is going to go up. Well, in fact, what they saw, this is on the launch pad, so on 1G, then this is during the acceleration of the launch, right here. And then this is the instant that the engine stopped firing and they went into 0G. And instead of going up, the central weakness pressure actually went below where it was pre-flight supine by a few millimeters of mercury. And initially I thought, oh, there must be a problem with the instrumentation, or the zero offset has been changed. We checked everything and found out, no, in fact, this is really what's going on. And they were able to confirm this with a couple of other astronauts on a subsequent flight. So there are some paradoxical things going on here. The heart seems to be getting bigger with intrathecal weightlessness, and yet the pressure in the heart is lower. And then eventually, once physiological processes balance out, the heart tends to be filling less. So what's going on? So that was actually the beginning of a project that we whimsically called the Hertz in Space Project. And it involved student, staff, and faculty at the University of Utah, Utah State University, and Bellarmine College here in Louisville, actually. It's a whole other story. But so the three of these organizations were working together to answer the question. And as we thought about it, there were two challenges, one of which is, how do you make cardiovascular measurements that can give you insights? Well, fortunately, we're used to doing all kinds of things with artificial hearts, and we have mock circulatory systems to test the performance of the hearts, but we can also use these mock circulations to do physiological experiments. And so the thought was, why don't we come up with a mock circulation that will work in weightlessness? And that's the first challenge, is having it work in weightlessness. That we can then instrument and see, are we seeing something in the pressures and the flows that are giving us clues about these anecdotal observations that have been made in crew members. And so what we proposed was that the hydrostatic pressure in the heart, which is dependent on acceleration, in this case gravity, when this goes to zero, this component that contributes to filling, those 5 factors that I mentioned before, that goes to zero. And if that's gone away, then you would predict there would be less filling. There's still the problem of initially there seems to be more filling, but for this experiment, we're just going to focus on what is a factor that could contribute to the reduced filling. And so to begin to answer this question, you can imagine most astronauts don't like pressure sensors and flow probes put in their hearts before launch. So we recruited a artificial astronaut, our heart, and in his artificial heart we had pressure sensors both at the base and at the apex, so we could measure the hydrostatic pressure difference in his atrium, in his aorta, and we also had a flow probe to measure how much flow his heart is generating. And we adopted the left ventricle that was part of the Utah 100 artificial heart that we developed at the time, and put together all of this brain and muscle power to come up with an experiment that we could fly during brief periods of weightlessness on a NASA zero-G aircraft. What you see here is the mock circulation and then the instrumentation rack that had all the pressure and flow and recording data. Here you can see Keith. Tom Bennett was a faculty member over at Bell, and Tom Scherfranz was one of his students. He's now a physician at Louisville. Scott Everett is now the chief toxicologist for the health department in Utah. Barbara Bennett was an engineer at NASA. So all these folks and a lot of other folks that were making this possible. And NASA, at that time, they flew a modified 707 that the wings were reinforced, fortunately. And what they would do is you get up to about 24,000 feet, the pilot would put the throttle full forward, it would nose up at 45 degrees, just like it shows in the picture, and it would keep climbing. Along about 32,000 feet, they pull back on the throttle, but the momentum was such that the airplane and everything in the airplane would continue to coast upward to about 36 to 38,000 feet, and then start to coast down over the backside. And during that coasting phase, relative to the aircraft, you are weightless and you are floating. And so you can get about 20 to 22 seconds to conduct an experiment or perform a task, whatever it is that you need to do when you're weightless. Now, of course, there is no free lunch. And after you get done with that 0G period, you have 40 seconds of 2Gs as you're pulling down and pulling up into the next maneuver, with a few seconds in between for each transition. And typically on a flight, we would fly 4 sets of 10 parabolas, so you get 40 parabolas altogether. Most of the time they were 0Gs, but you can change the trajectory a little bit and also simulate lunar gravity or Martian gravity that we've done on occasion. So this shows you the profile, the 0G period. And this is some of the data that we saw, which supported our hypothesis. Compared to 1G, you can see that in 0G, within measurement error, the hydrostatic pressure difference between the base and the apex of the ventricle went to 0. And so we were eliminating that component that contributed to heart filling. And likewise, the function curve, without that, it shifted to the right, which means that at the same filling pressure in 0G, you're going to get less filling and less cardiac output. The limitation with the 0G flights is that you don't have time to regulate the aortic pressure and some of the other things, and so that really necessitates the need to have extended exposure with 0G to make a more elaborate evaluation. And so we started to condense the experiment, make it automated, because we had been accepted into a program that NASA had at the time to fly educational experiments on the shuttle in what they call getaway special canisters that were about the size of a 20-gallon garbage can. And you had to fit your entire experiment in there, your power, whatever was running it, and all you got was a connector, and the connector went to the flight deck, and there was one of the astronauts would go through a sequence of commands to turn it on, and after that, you had to do everything. So we had electrical engineering students working on all the electronics, the automation of it, the microprocessor, mechanical engineering students working on the design, and they're all working on assembling it and testing it, so it was a great deal of fun. So this is the first attempt to reduce the size of our, what you can't see is there's still one umbilical going back to the big instrumentation rack. But at least we demonstrated we could make it smaller and still get some useful data. And then here you can see our almost fully automated during another flight. The one thing that Keith and I learned when we go to fly with NASA is that sometimes unusual things happen, like there's unusual experiments or there's astronauts on board trying something. On this particular flight, it was the familiarization flight for the cast of Apollo 13. So you might recognize Tom Hanks and Kevin Bacon floating over me in an experiment. If you've seen the movie, the way the scenes in the movie were filmed on the airplane. NASA, Imagine Entertainment contracted 12 flights with NASA. So if you ever get to see that movie, you'll get a chance to see working in weightlessness that looks believable because it is. So this is our finally configured for the spaceflight on the space shuttle. This is the experiment package right here, the data recorder. Down here is all the supporting electronics. And the back was a sealed battery box where all the batteries were that took the power the experiment. We were your typical academic, student-based experiment that depended on donations from lots of folks, including Duracell that donated about $5,000 worth of batteries for all our people, and finally our 2 flights. So Art got buttoned up inside his getaway special canister, took off, came back several days later, and fortunately had some data. And when we reconstructed the 1G upright function curve compared to the 0G, we did see, as we'd seen previously, a rightward shift of the function curve that confirms our hypothesis that the absence of hydrostatic pressure is going to reduce cardiac diastolic function. The other data here, supine, is, if you go supine, you're still going to have a hydrostatic pressure difference, but it's going to be smaller, so you would predict not quite as big a decrement. Supine data lie between the 1G upright and 0G, as you would at least conceptually predict. Now, time is running faster than I thought, so I think what I'm going to do is to skip past some of this and get on to some of the other things that we've done. Now, understanding physiological processes is one of the things you do when you're doing experiments on the aircraft. Another thing you might do is develop medical procedures or emergency medical procedures. And we did a project where we were looking at how, if a crew member had a cardiac arrest, how would you start to initiate cardiopulmonary resuscitation? Anybody here been through CPR training? Okay, so the victim is laying on the ground. As the rescuer, you're kneeling next to them. And what you do is you put your hands on the sternum and you force it down to compress the sternum, to press the heart, to pump some blood out. The reason why you can do that is gravity is holding the victim to the ground and gravity is holding you to the ground, so when you press down, force will be transmitted. Imagine doing that if you're in a zero gravity condition. Newton's second law wins every time. If you go to push down, you're going to go flipping backwards because for every action there's an equal and opposite reaction. So the challenge is, how do you adequately maintain contact with, as the rescuer, with the victim so that you can successfully transmit the force of a chest compression to try to augment some blood flow until you can get their heart restarted. And so we looked at 4 different ways of trying to restrain victims and rescuers. And 2 of them used strapping systems, which makes a lot of sense. You strap yourself down next to the victim, you strap the victim down, and then you can at least get some counter force from the straps that will allow you to transmit force to the victim. One variation on that was we had an extra set of straps that came across the victim, so you had 4-point fixation to try to create a counter force. The third was a modified Heimlich maneuver, where you would place your hands higher up on the torso, above, across the heart, and wrap yourself around the victim and start squeezing. And then a 4th method called vertical CPR. I suggest you not try in 1G. It's where essentially you do a handstand on the chest of the victim, put your feet on an opposing surface, and then push down. So that's probably best reserved for 0G. Now, the whole reason CPR works is because conveniently the heart is located between the sternum and the spinal column, 2 fairly rigid anatomic structures. So if you press down here, you're going to squeeze the heart, blood is going to be ejected. And if you do that in a cyclic way, where you compress and then relieve completely the compression so that the heart can feel again, you can generate enough cardiac output to keep the person biologically viable until you can get their heart restarted. So we did 2 different sets of experiments. In 1G, we did a set of experiments where we had volunteer, healthy, I might add, test subjects. And we instrumented them, so we were measuring their arterial blood pressure, near the arch of their aorta, their central venous pressure, the pressure in their chest and their abdomen, much like I showed you before, their electrocardiograph, and we also measured their oxygenation in their brain and kidney using NIRS technology. And this is the setup in the test room doing side straddle CPR. And here's where the other straddling system. You might notice we actually have a force transducer between the rescuer's palms and the sternum so we could record the force at the same time. And then this is backward bear hug or modified Heimlich CPR. This is an example of the tracings. The red is the central arterial pressure. The yellow and the purple are the intra-abdominal and esophageal pressures. The green is the force transducer. And then the yellow is the electrocardiograph. And the goal was to deliver a chest compression every third beat and do it synchronous with systolic or simultaneously with the QRS complex. So what you're looking for is an indication of augmentation of peak arterial blood pressure. For safety reasons, you don't want to do it during diastole. That can create a situation called commotion cordis that can cause instant cardiac fibrillation, which you want to avoid. Well, what you can see here is that with each compression, the pressure in the chest and the abdomen goes up, but you also see there's this bump in the peak arterial pressure. And there's actually an increase in the difference between the central venous pressure and the peak arterial pressure, which is called coronary perfusion pressure. So clearly, the chest compressions are effective for accomplishing what you want hemodynamically. If we look, for example, at the coronary perfusion pressure in a beat where there's not a compression and a beat where there is a compression, you can see in all cases the coronary perfusion pressure goes up quite significantly. Likewise, with the intraesophageal pressure, in this case with a modified Heimlich maneuver, in each case you get a substantial increase in the intraesophageal pressure that's going to help compress the heart to generate some of the blood flow. So all these techniques physiologically are working the way we hope that they would. Now, we wanted to repeat this on the zero-G airplane. Unfortunately, NASA is not quite as ambitious and adventurous as we were. So we could get an experiment approved where we had a CPR training manual, where we had it instrumented with a force transducer and a depth of compression transducer. We repeated the 3 chest compression techniques we did on the human subjects, plus we had a vertical CPR. So here you can see side straddle with the waist strap. Here's side straddle with the extra straps on the opposite side of the victim. And then here's vertical CPR. You can see why I suggest you don't try this in 1G. And then here's backward bear hug or modified Heimlich in 0G. By the way, I should point out, vertical CPR, there's a couple of challenges with it. One is that because you're weightless, if you go to relieve the chest compression, you're reluctant to relieve it all the way because you don't want to lose contact with the victim. Because if you float away, it takes a lot of time to get relieved combined with it. That could reduce the effectiveness of the chest compression with vertical CPR. The other thing is that because your vestibular cues are altered when you're weightless, if you put your hands down on the victim and then stretch your feet up to the opposite surface, when you think you're going straight up, the legs are actually going back at a substantial angle, and that reduces your CPR chest compression effectiveness. So one of the advantages of having additional people to monitor was they can actually help you get your feet perfectly vertical, but it's an important lesson in self-orientation in weightlessness. So again, here's the depth and force of chest compressions to a simulated ECG when we went through the period of 0G. And what we found was pretty much with all 4 of the techniques, we could develop pretty darn close to 100 pounds of pressure, which is quite good for a chest compression. And the depth of the compression was about 1 3/4 inches, which is pretty close to the recommended level. So given the observation that you can generate adequate force and depth of compression, then what's going to influence what method you're going to use is which can you initiate rapidly, because the time of starting first chest compressions is directly related to the likelihood of that person being successfully resuscitated or not. So in this case, with the backward bear hug, it's a matter of observing the victim, doing your assessment, and then starting the chest compressions. And you can do that in very short order, just a few seconds. In the meantime, somebody else on the crew can either relieve you or go get the automated chest compression device that's in the locker that's 2 modules away. Likewise, if you had to get straps, that's going to delay time to your first chest compressions. So the recommendation from this study was we start your chest compressions with the backward bear hugs. In fact, that's one of the, based on the study that Keith did, that's one of the recommendations that they now make when they're training crew members on how to give chest compressions as emergent. One other little anecdote, you might guess that there is a little difference depending on who the rescuer is. So what you have here is a short old guy, a tall young guy, a short young guy, and a tall old guy. Now, and it all depends on how you display your data. If you lump all of the test subjects to the 4 different techniques, you can see from the box plots and all that, they look pretty darn much the same. But if you separate it out by rescuer, you can see that these 2 rescuers were much more effective than these 2 rescuers, and you can guess who these guys were. So the lesson there is, when you're working in weightlessness, pick your partner carefully. Now, this brings us to the current project that we're working on. As mission planners at NASA are looking 15, 20 years down the road for exploration missions, one of the things they want to consider is, how do we provide basic surgical capabilities for exploration spaceflight? Typical situation, what if you have a crew member who has an acute case of appendicitis? First thing you do is you try to treat it medically. But if it doesn't respond to medical therapy, then you have to do an appendectomy. And doing an appendectomy in 0G may not be the most straightforward thing. So one of the things with any surgery is you want to contain and control the operative site, or if you've got trauma, you want to contain and control it, especially in weightlessness, because you don't want something floating through the spacecraft to contaminate the surgical site. Likewise, you don't want blood squirting or tissue floating outside of the surgical site and contaminating the spacecraft. Not to mention, how do you keep your instruments from floating away? How do you manage your intravenous fluids? Because fluids behave very differently in 0G than they do in 1G. So what this project has done is starting to look at some of the details of what it's going to take to perform a simple surgical task in 0G. And this project is one that's being conducted in collaboration with colleagues at Carnegie Mellon University. And in fact, one of the fellows there, who is a neurosurgeon and actually originally proposed this concept for neurosurgery, envisioned a clear plastic dome that somehow or another had a magical sealing perimeter to it, so you can stick it over the tissue, and then you fill it with irrigation solution that keeps the dome clear, and also you can increase the pressure if there's bleeding to slow or stop bleeding until you can stick a cautery tool or endoscopic surgical devices in these ports that hopefully don't leak to take care of the problem, and then continue your surgery. And then when you're done, you drain the dome, peel it away, and you've got your surgery completed. And then all of the engineering system that you take to support this. So, since we're going to be dealing with a lot of fluids, NASA requires you to have a secondary containment chamber. And when we started working on the project, the simplest secondary containment chamber we could think of was to get a canopy from a neonatal intensive care unit incubator and convert that into our glove box. And anything that we were going to be doing goes inside that glove box, which is bolted to this mount, that's bolted to this plate, which is bolted to the floor of the aircraft so that nothing floats away. One of the first simple surgical tasks we ask is, when you're weightless, can you efficiently suction? So one of the students created a model chamber where you could create simulated bleeding, and then the idea was, could you direct the tip of the surgical suction wand up to it and successfully suck it into the tip of the wand? And we were able to demonstrate that you could do that, but one of the things that we didn't anticipate, this particular chamber is quite rigid, and even if you had a dome over compliant skin, it's not going to be fully compliant, is that when you're suctioning in this chamber, the pressure goes quite subatmospheric. So it went from 0 down to minus 84 millimeters of mercury. That's not a good situation, because you could actually induce bleeding from other sites if the pressure went down. So one of the challenges now, in fact, one of the things that one of the senior design teams is working on, is creating a control that when you suction away fluid to remove blood and debris, you add at the same time, at the same flow rate, a replacement immersion fluid so that you don't see any change in pressure. Now, one of the other things we found out was we were using commercially available trocars, or ports that you use to introduce endoscopic instruments. What we've experienced is they all leak. And actually, so we started to look at two things. One is the design of the instruments, and we looked at the design of commercial ports. We tested a lot of them, and then we started looking at what would we do if we made our own port. It became very clear that because of the design of the surgical instruments, it would take a lot more effort to redesign the instruments, particularly their tips, than it would to redesign the trocars. And ultimately, what we've come to is a new design that incorporates a series of valves and a different kind of diaphragm seal that seals around the shaft of the instruments, so that in the entire process of inserting the surgical instrument, like this, manipulating it, doing whatever you need to do with it, and pulling it out, that there is no leak. That way you don't leak and contaminate the spacecraft, plus you can also maintain the fluid pressure inside the containment chamber. And so that's, we've developed these leak-free trocars that are similar in size to the commercially available ones. You can see on this real simple leak tester that we've got in the lab, we run the pressure in excess of 200 millimeters of mercury, and they don't leak. For laparoscopic surgery, usually only you need 15 millimeters of mercury. If you were going to adapt the system for arthroscopic surgery, so for knee or shoulder surgery, they might go up to 70. So having this kind of leak capability actually is quite useful. Yeah.
Do you have to counter the pressure when you're inserting and pulling out, because you're essentially creating the pressure like piston and then a vacuum when you're pulling in and out? If you've got a full seal around.
Yeah. Yeah, in a rigid system, you're actually absolutely right. In fact, with this tester, when we'd start at a stable pressure and then we'd put it in, and we would actually see the pressure go up for the very thing that we talked about. When you're dealing in the body is more compliant, and you're not going to see nearly as much a change in the pressure. But it is important to recognize that if you do see the increase when you put the instrument in, or a decrease when you pull it out. I'll mention a couple of other things in some tests that we've done related to that. So these are the trocars as they currently exist, all the different components that get put into it. This is one of the smaller ones right here for a 5 millimeter shaft instrument. We also have a bigger one that can accommodate 10 to 12 millimeter instrument, like a stapler scalpel instrument, something like that. And the diaphragm seal is one of the unique features it tapers on both sides, and the consequence of that, as you can see, is that as you're inserting your instrument, it can stay conformed nicely to it, and as you withdraw, it stays conformed to it, so it maintains the seal. And then related to your question, we've actually conducted 2 laparoscopic procedures in fresh human cadavers. This is with Dr. Erica Sutton down at the medical school. And one of the things that we were watching is when you put the trocars in, when you put the instruments in, do you see the pressure in the abdomen stay the same, or do you see it go down and an increase in the CO2 that's having to flow in and maintain it? And what we've seen is that the pressure is very well maintained as you're introducing the instruments or pulling it out. And in this case, working in the abdomen, we haven't really seen any pressure changes when the instruments are being inserted or withdrawn. But my guess is if you're doing an arthroscopic case where you have a smaller joint capsule, you would probably see some pressure fluctuation in that situation. So then we've incorporated these trocars into some of the domes for more zero-G flights. What we have here is a piece of latex tubing that's simulating a kicked bowel. And so during a zero-G period, Morgan is a med student, actually he's now a surgical resident. Trey is one of my other students. They're actually seeing if when they're weightless using a surgical stapler, can they staple and cut this simulated bowel, and it turns out it worked out pretty well. We've done a lot of other things looking at how effective suturing can be compared to stapling. We've worked on the tissue interface, trying to figure out how to adhere surgical drape material to the flange of these domes so that you can stick it to the skin and still maintain a pressure seal up to about 70 millimeters of mercury. Here you can see this is a leak test one of these interfaces, and this is a test really applied to a aluminum test subject. And then this is a couple of photos of actually doing it in zero-G. And then the filling the dome is a challenge because you don't want to trap air bubbles because those can cause visual distortions of the surgical field. And when I'm done here, I'll turn off the PowerPoint and I'll show you a little film clip where you can actually look at filling in 1G and then in 0G and see the difference. But from a physical point of view, and this is very simplistic, the big difference is you don't have hydrostatic pressure. If you think when you fill a glass in 1G, it flows from the bottom up because hydrostatic pressure is keeping the fluid down. But in 0G, it will float away. Now, with these domes, they're circular, and the inflow port is tangential at the base, so we are intentionally trying to create a vortex. But we can't fill it too quickly because the angular momentum is going to make it crawl up the sides, and you're going to lose control of your air-water interface. So you need to fill it just enough to keep it filling, and then have the interface eventually roll out before you trap an air bubble. And then this is part of the control system that Tommy and some of the students have devised to automatically control the filling, and then sense when it's fully filled to stop the filling. What we're trying to go to is a simple push-button operation to minimize the amount of interactions that astronauts would need to do. We're also working on reclaiming the fluid from the dome, which during the procedure you're going to suction some fluid off. At the end of the procedure you're going to drain the dome. So it's going to have blood, tissue, surgical bits in it. NASA has a water recovery system, this system right here, on board the space station that will probably be adapted in some form for future spacecraft. What it does is it takes urine and it takes other fluids from the spacecraft, goes through multiple distillation and separation processes, and ultimately what it does is it creates drinkable water from this. So that minimizes the amount of water that you have to take with you, so it reduces your source. there's a technology group up at NASA Glenn in Cleveland that's then figured out that they've created a little box that takes this drinkable water and converts it to either sterile water or sterile saline that could then be used for surgery. So in one of the experiments that we flew last September, here we have a bag that's full of saline, blood, suture bits, surgical staples, and pieces of tissue. And what we did is, in zero-G period, first put it through a 20-micron filter to try to remove the physical particulate, and then put it through an absorbent filter to try to remove as much of the protein as we could, and then finally collect it. And what we found out was that the physical filter did a real good job of removing particulate. And then this is progressively, this is a sample after it's gone through the absorbent filter. It does a real good job of removing the protein to the point where fluid like this could then be put into the urine processing system and ultimately come out as drinkable water. So there's merit in this if we can condense it and make it simple enough that it's from a weight and power budget, it makes it, you reclaim, what you reclaim is worth the investment. Now, this is what's coming up in the near future. We had 6 zero-G flights last year. We don't have any this year. We're hoping to get some next year, but what we do have next year is a suborbital spaceflight. There are a few different suborbital spaceflight opportunities. The one we're looking at is called Spaceship 2, run by a company called Virgin Galactic. And Spaceship 2 gets carried underneath the carrier aircraft, and once it gets up to 40,000 feet, it gets dropped, and then the rocket motor in the back lights up, and it takes it up to around 65 or 70 miles. Once the engine cuts out, you've got weightlessness. It continues to coast up to the apogee, and it starts to come down, and then it glides back down. And then it'll give you, depending on the engine burn, 3 to 4 minutes of continuous zero-G. So the plan is now we want to fully test the fluid management system to fill and detect automated filling, to do pressure regulation, to do suction without pressure change, to purge some analog blood that we inject into it, and then to empty it. And we should be able to do that in the 3 to 4 minutes, and so all be automated. So we're getting this ready to fly right now. A couple of the student teams are working on different components of this. And because our glove box that we've been flying on the zero-G airplane is too big to get through the hatch of Spaceship 2, we've had to design and construct a glove box that is just a little bit smaller, but it will accommodate the experiments and fit through the hatch. And this is the glove box in its current configuration. We're working on more of the details, and it should be done probably in the next couple of months. And in the meantime, we're getting the experiments to the point where everything will fit and operate correctly in an automated fashion. Flying on Spaceship 2 is a possibility sometime in the future. And I had a chance to be the first test subject in a study where the question is, how healthy do you have to be and still tolerate the acceleration level? Because during the launch phase, you'll get 6 Gs front to back and 4 Gs head to toe. And then during the re-entry, you get about 4 Gs head to toe and 4 Gs front to back for a couple of minutes. And it's tolerable. You have to learn breathing techniques and a few other things, but it is quite tolerable. So the hope is that once Spaceship 2 starts flying reliably, that commercial passengers will fly, and then we're hoping that commercial scientists can also fly on that. And with a surgical experiment, you can only do so many things automated. Eventually it gets to the point where you have to have someone who is a surgeon trying it out, just like they're going to be doing during a spaceflight. So we're hoping that maybe in a few years from now, we can have somebody on our team flying Spaceship 2. So at the end of a good experiment series, it's nice to congratulate yourself, in this case with a floating high five. I'd like to thank you on behalf of all the team. ask if you have any questions, and say thanks again. And if you're interested, I've got a couple of videos I'd like to show you.
Sure.
Yeah.
So he's getting those ready. Everybody, thank you.
The first video, if I can get it to come up here, is an example of filling the dome, and I want to tell you what you're, just a second. For some reason,
It's hard to do. Walking and chewing.
oh, what the heck, I'll just let it run.
Just talking now. I'll do it.
Thanks.
I'll just go back to the start.
So what you're looking at is one camera looking down on the dome, both from the top and at the view in a right angle mirror, a 45-degree angle mirror, so you're seeing the lateral view simultaneously. This is in 1G, and as you expected, it has a flat interface that goes from the bottom to the top as it fills. Same dome, same inflow rate in 0G, and as you can see, the fluid forms a vortex, it crawls the walls, and eventually the interface collapses without trapping an air bubble, which is what we want. That's desired performance. Same situation, some flow disturbance takes place, and you'll notice that before it empties, a big air bubble gets trapped, which is not acceptable like that. And in the last one, we now have a concave geometry, which changes the influence of the angular momentum. And this one fills very reliably every time without trapping air. But what we've since learned is that the concave geometry, or even a conical geometry, which is a trade-off between the hemisphere and the concave, creates some visual distortion of the field, and it also limits how much it can do with surgical instruments. So we've made the decision for now is that we think we know how to confidently fill the hemispherical dome, which gives you much better visualization and much better manipulation of the instruments. So that's going to be the dome geometry we're going to continue to explore.
Any questions?